Shot. Okay, welcome to the Deuk Spine Institute's live stream. We are now starting our third surgery. Shot. And this patient, she comes from Washington. Shot. Oh my God, I'm just so off today. The last patient is from Washington. Thank you, thank you. She's from Naples, Florida. I apologize. Where do you feel that?
Where are you feeling that? In the back? Okay.
Shot?
Just finding the right spot now.
You're doing great. Just give me a minute. We're going to be where we need to be and we can put you to sleep. Shot? All right, so at this point I'm trying to access the disc at 54334 on the left side, AP. We're going to get another view through a front back. I'm going to give you some more numbing medicine, all right? So far, everything's going real well. Don't be alarmed that you're awake. You're supposed to be awake. Shot. All right, back to a lateral. You're doing great. So, I'm going to try to go a little more medial. All right, I'm hitting the facet. Shot. Where do you feel that? In your back? I can't hear her.
She says in the back.
Yeah, that's what I expect. We're right on your painful facet joint. You're okay. Hang in there. We're almost done. In your back? All right, sorry about that. That's one of your bad discs. Shot? Boy, it's interesting. You feel it in your back, right? Is that better? Let's get the next level, Monica. So it's a left 3, 4, 4, 5. Shot. All right, that was definitely a good move. See how off you are on orbit right there with the facets of 4? Or sorry, 5. Superior facets are way off. Keep going, just a little more. You're off on WAG. Yeah, that's better. Definitely making improvements here. I think you're off on WAG by 1 degree. Shot. You went the wrong way. Shot. All right, that's pretty close. Maybe a little more on WAG. Shot. WAG shot. A little more. WAG shot. That's pretty good right there. That's about as good as we're going to get it. All right, so we're just lining our x-ray machine up. Remember, we're navigating. We need to navigate to the bad part. Let's get some num-num. Shot. That was it. Good job. Yeah, go. Go ahead. Inject. Good. Enough. We're giving you more numbing medicine. You're doing great. Just relax. Shot. All right. So you can see I'm approaching her facet. Shot. I'm going to change the orientation of the needle and aim more medial. Shot. Right up against the facet. Perfect. Where do you feel that? Your back? Huh?
Back and where? Feel you in the back? Back.
That's your bad disc, sweetheart. All right, so we've done 2 discs so far. Well, let's go down and show the sacrum just so everybody can see. I need them then. And we're going to do the same 2 discs on the right side, plus we're going to add 2, 3. That's good. That's perfect. So you can see that we're at 3, 4, and 4, 5. Everyone agrees? I've given you some more numbing medicine. And now I'm going to access those discs on the other side. Shot. So we're going to do the same discs on this side. And then we're going to do the one above. Shot. Can you move that cable, please? Why did you... Okay, so you just went south. Is that what it was? Yeah. Mm-hmm. Shot. All right. I need you to get that lined up. Do you see the double shadow on the superior of the L5 facet? Or pedicle? It's a WAG issue. It's not an orbital issue. Monica, it's taking too long. It's a WAG. You're still off on WAG. Shot. All right, still off on WAG, big time. Mm-hmm. There we go. It's better. A little bit more. That's. I think you might have overshot a little bit. Shot. Mm-hmm. All right. So Henry, shot. Let's get a AP at this point. Henry, any questions from our audience?
No current questions, so we do have a comment from Brian Powers on Facebook saying, there's no way I could be awake for this. When I had a myelogram done, I thought I was going to die.
No, you didn't get the side I need to see. Yeah, Mr. Powers, you bring up a great point, and I appreciate that. So to answer your comment, she's not really awake like you think she's awake. She's sedated. She's a bit out of it, but she's still awake enough to answer and talk, but she's not like fully there like you and I are talking right now. Shot? That's it? All right. So she's a bit sleepy, a bit out of it with the medicine, but she's awake enough that I can have somewhat of a conversation with her. Okay, shot? All right, so we are in there. All right. But I appreciate your sentiment. And a myelogram is a different procedure, as you know. A myelogram is a procedure where they're sticking dye inside your thecal sac around your nerve roots. It's a very uncomfortable situation. We're not actually doing that. We're staying in the back of the spine and kind of going around the spine. Shot. Shot. So it's not quite as painful as a myelogram would be. A myelogram would be a more painful procedure. Shot. You okay?
How are you doing?
AP. She all right? Reliable? Yes?
Having any back pain right now? No leg pain?
Perfect. Doesn't get any better than that. So at this point, we've lost about 5 drops of blood. Shot. We're about to enter 3-4 on the right side, which was our next target. Shot. It's perfect. And then we've got one more to go, which is number 2-3 on the right. Everyone agree? 2-3 right? Now let's see if we can do it through this incision. I purposefully made the incision a little higher than I want, but just so I can get up to 2-3. Shot. And use the same incision. That would be ideal. Shot. That's it. All right, so I'm just a little bit, there we go, shot. Too low. Shot. Much better. I'm just hitting her facets. It's her back. Shot. It may be her TP. I may be hitting her transverse process. That's what it looks like. Let's get an AP. I bet it's a transverse process. If that's the case, I may have trouble sneaking around that. You can kind of see it over there on the, looks like a bubble. All right, let's get that. Yep, I'm hitting her transverse process. So I'm probably going to have to do a separate incision for 2-3. Shot. I just don't think I can get around it, but I'm going to give it one more effort. Yeah, it's hitting the TP, and it's deflecting me north. And it's deflecting me so north that I'm not going to be able to get it. So I'm going to just put this third one through a separate incision. Num. It will be a little more medial in the entry point and a higher, obviously. Shot. That's looking good. Shot. What's that noise, Luis? Shot? That buzzing right over my left ear. That's the pressure machine? Alright, just about there. Shot? Huh? It sure is. Where do you feel that, Shot? I feel her herniation. I'm right on it. Yep. All right, let's wake her up and let's test her. Okay, so at this point, we have successfully gotten into the 3 discs on the right side and then also on the left side. So we're doing bilateral because she has bilateral leg symptoms. Now she came to me and she has obviously pain that is primarily legs but also back. She has 3 discs that are damaged. L4-5, L3-4. Can you guys see this okay? Henry?
Yes, we can.
All right. She's got tears on this side at 2-3, on both sides at 3-4, both sides at 4-5. Are you comfy?
How are you doing? You okay? He said yes.
All right. Is she reliable? Awake?
Are you with us? She said yes.
Mm-hmm. Are you having any back pain?
Are you having back pain right now? Yes or no? Any back pain?
Yeah, come south a little, just a tiny bit. All right, no back pain. Now, how long has she had pain for? How long have you had your pain for?
How long has that back pain? How many years? How long? 7 years? 7 months.
It's probably longer than that, but let's just put 7 months, which is good that we're getting to it sooner than later. You comfy? She reliable? Oh, look at that. You can hear her shot. That was, yeah.
What number is that?
All right,
0
show
or
us
10?
the tear.
What number? 10.
10. Is that where you get pain? That is 3-4. Is that where you get pain? Yes, she said yes. So it's concordant. So L3-4 is 10/10. Is it better? I'm sorry. I'm very sorry. But we had to test the discs. You guys could see the annular tear at 3-4. Is it better now?
Is it better now?
right. See her come up? How bad is that on a scale of 1 to 10? 10. Is that where you get pain? That's L2-3 concordant. I'm so sorry, sweetheart. We're going to be able to put you to sleep in about 1 minute. All right? So, folks, what we've done is we've tested 2 out of the 3 discs we're fixing to see if they're causing her back pain, and they are. 10 out of 10, concordant. Concordant means it's her pain she gets every day. Is that better?
Feel better?
How bad is that on a scale of 1 to 10?
10. She said 10.
Yeah, you can see the tear. Another 10. So you get to go to sleep, and when you wake up, we'll be done, sweetheart. Is that where you get pain every day? Yeah. All right, so while we're putting her to sleep, I'll talk to you guys. This patient came with chronic back pain like everybody. I figured out it was based on her exam, based on the MRI and my experience. It was coming from these 3 discs, number 2, 3, 3, 4, 4, 5. If you look at her MRI, the L5S1 is perfect disc, nothing wrong. I didn't think it was coming from there. We just confirmed my diagnosis. She has 3 discs causing her back pain. It's horrible. You saw her arch up when I injected. She started to groan and moan. We asked her how bad it was on a scale of 1 to 10. She said 10 out of 10, all 3. And I asked her if that's where she gets her back pain every day. She said yes. So you wanted to know why the patients are awake. They're awake for 2 reasons. Number 1, in the beginning they're awake so we don't get too close to the nerve root. If we do, she'll tell me she has pain down her leg, and I have to adjust my trajectory. Look at that. Isn't that cool, guys? We didn't inject dye on this side. We injected on that side, but you can see it on this side because it filled the disc. All right, the second reason patients need to be awake is that we need to do a discogram, which we just did. It's a confirmatory test confirming the diagnosis of discogenic back pain. I'm going to move. Henry, why don't you show our audience the video as to why people get back pain from a herniated disc, okay?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, at this point we are now inside the disc. We have 5 areas to repair. This is the first of 5. Oh, by the way, for those of you who watched our earlier surgeries, both of those patients are already gone. The gentleman that we did last, 511, I need laser.
I want that light off, please. Thank you.
He's already gone. The cervical from earlier today gone. And they're both very happy. Their pain is gone.
We have a couple comments.
Yeah, let's read the comments.
This first one comes from Sheila on YouTube.
Hello, Sheila.
And they said, I'm having a decompression on my L4-5 on July 11th after a 4-year wait.
Yeah.
That's it.
Yeah, Sheila, it's not going to fix your problem. I hate to say it, but a decompression surgery is not a good surgery. First of all, there's only a few ways to do it. One is called a laminectomy. The other is called a microdiscectomy. Both of those surgeries are highly invasive. They cause a lot of trauma to your spine, to your body. You'll be in horrible pain. And more importantly, they don't address the problem. The problem that's causing your pain is not compression. The problem causing your symptoms is inflammation. And that's what we're doing here. We're treating the inflammation. So if you want the right surgery for your problem, you need the Deuk laser disc repair. I'm just telling you, okay? Don't shoot the messenger. Isn't that what they say? Don't shoot the messenger. We're not doing a decompression here. We're doing a inflammation treatment. Getting rid of inflammation. That's where our pain's coming from. But thank you for sharing. I hope you'll reconsider your plans. And be my advice for you to do a free MRI review with me and get some answers, so we can talk face to face.
Thank you.
Okay. What is it, Sarah? Whew. Sarah? Are you here? I mean mentally. We know you're here physically. All right. All right. Huh? Oh, okay, no problem. Henry, we're ready for the next comment.
Next comment comes from Brian Powers, once more on Facebook, and they said, following about their myelogram, they said, Brian said, they said I had spinal canal blockage back when I had emergency surgery in '96. So that's why they did the myelogram. Thanks again for answering my comments and questions.
Yeah, no problem, Mr. Powers. So 96, I hate to say it, but we did have MRIs. Maybe they didn't have an MRI where you were, and that's fine, because MRIs back in 96, they were starting to get more popular for spine problems. But where I did my work, we had MRIs, and we were able to pop patients into the MRI scanner and, of course, do a quick MRI. But a myelogram, the problem with the myelogram is it's so dangerous to do, sticking a needle in your spine, but more importantly, if you notice where I put the needle, I'm putting it in the disc. The disc is relatively safe, but with a myelogram, they're putting the needle in your thecal sac, it's called. And the thecal sac is the thing that has all the nerves around it. And the problem with myelograms is you can cause meningitis, which is inflammation of the meninges, and it's very bad with the myelogram. So it's a dangerous procedure. You can get an epidural hematoma, you can get meningitis, you can also get arachnoiditis, where the nerve roots stick together, and people get this leg pain that can never go away. It's called arachnoiditis, and it's from scarring of the nerve roots, and it's actually from the procedure, the myelogram. So I never do myelograms, ever. And I realized it was back in '96, which is a long time ago. So back then maybe the hospital and surgeon, they didn't have an MRI to do it with, you know, but thank God we have MRIs now, so we don't have to do myelograms anymore, you know, emergently. But thanks for sharing your story. What's that? Yeah, I'm wondering, yeah, you may have some residual problems from your myelogram. Dr. Berndes is mentioning, he's right. Certainly possible. Again, look up arachnoiditis. That's where the nerve roots stick together. Oh, I've seen so many people with that. And they all had myelograms, you know? They all had myelograms. So thank God MRIs were discovered and have become more common. Man, MRI scans, what an invention, huh? One of the best inventions ever. Thank God for technology. You wouldn't want to do alcohol anesthesia, would you? Laughing yes. All right. Next comment.
This next comment is actually a question. This comes from B3 on YouTube, and they asked, how many of these life-changing procedures do you perform in a day?
Yeah, B3. Today's a busy day, I know. We've gotten consistently busier and busier. The truth is. And people recognize what we can do for them, and they're traveling from all over the place. Now, I had 3 from Florida so far. I keep thinking they're all from Washington, but one of them is. It's the last one. We've got one more to go. How many can I do in a day? Basically, it's a bit of an unusual day, to be quite honest, because not only are we doing, it's a long day. We're only doing 4 patients, but the reality is each patient is requiring an extremely long and arduous procedure. So normally I would see like a patient and do 2 discs, right? Like an average of 2 discs per patient. But today we're doing 2 4 discs or 2 5 spots, and plus on top of that plasma rhizotomy for facet. So it's just unusually long and involved procedures today. We don't normally do this much per person. Huh? Yeah, a lot of combined procedures. Meaning we're doing the disc and the facets at the same time. And again, the only reason we're doing that is because I don't want to make people have to come back and get surgery again. I like to do it all in one shot. It's safer. It's less expensive for the patient that way. It's taxing on me and my staff. We're suffering through it. And so it's, huh? Yeah. Kudos to my team. So how many can I do a day? It just depends on how involved each surgery is, but I say we can tap out or max out at around 4 to 6, but only 6 only if it's like just 1 or 2 levels, not these massive cases. I call them massive. They're not massive from the sense of a big incision. They're massive from the sense of a lot of time needed to do the surgery. So, all right, we're done here. I'm getting out of this one.
Lights on, please. Thank you.
Yeah, today's a long day. Let me have a grabber. Actually, I'll irrigate it out. Scope off. Irrigation. Great questions from all of you.
We don't have a question, but we do have a comment from Brian once more on Facebook. And they said, thank you very much for all your information. I'm from Chicago, and they did an MRI first, then the myelogram. You have a great team, and I've watched you for a while now.
Hey, thank you. It means a lot. And honestly, having you all around here while we're operating, it makes it a lot nicer for us too, because I hate to say it, but sometimes the work gets a little monotonous, doing the same thing over and over again. And like I told you before, surgeons love monotony. They love having that stability where things don't change, right? Where you don't have to worry about somebody having a serious problem during surgery. So as much as I appreciate the fact these surgeries are not that exciting, I also appreciate the fact you're all here asking questions, participating with us, and being involved in the surgery. So I feel really good about this patient because after seeing her discograms, I recognize that all 3 discs are causing her pain, and we've tapped into all 3 discs on both sides on 2 of them. And I really feel good about that because I really feel like we're going to be able to get rid of her back pain with this surgery. So I'm pretty excited for her. And that's what keeps me going, is that knowing that this patient's going to not have this pain anymore the rest of her life. It's going to make a big impact in her life. You know, if I didn't have that to look forward to, I don't know that I could be here for the long hours that I'm here for. Now, I know where I'm going with this is safe because I've already shot. I've already put the needle, remember earlier? And I know that the path of the needle is safe. So once you put the needle in a safe path, then the guide wire goes down the middle of that. You know for sure that you're not going to hurt the patient as long as you don't go in too far. You know you're in the right trajectory. And that's the beauty of this surgery, is that the first step of placing the needle is the most important step of, let's go, basically making sure the procedure will be safe for the patient. So it's kind of nice, you know, with other types of surgery, you can have problems at any time. We can have problems at any time as well, but it's extremely unlikely because in the very beginning, that's where you do the hard part, is navigating the needle. But once you've navigated the needle successfully into the disc, look at that tear right there. That's crazy. Look at that granulation tissue. Right there. I'm going to laser that away.
Thank you.
That's where her pain's coming from, right there. Say goodbye to my little granulation tissue, Oscar. Say hello to my little friend. All right, let's get that herniation out. That's a piece of herniation right there. So what do we do with the indigo?
Oh, we double those.
You doubled it.
Yeah, for this case.
So I don't think it looks that much different, do you? A little bit? I mean, come on, Oscar. I think it looks better because the visibility is better. But I'm not convinced that it's darker blue. Do you think it's darker? Yeah? I mean, it's clearly better visibility than the last case, because the last case we had. You mean from before, yeah. Yeah, you can see the blue dye, guys, is sticking to the herniated nucleus pulposus, which is stuck down to the annular tear. That's a really good picture right there, Henry.
Copy that.
That wall right there where you can see the blue. I wonder if you could get that picture for me. Do like a screenshot later.
Yeah. That'll be up on the special cases folder tomorrow morning.
Yeah, that'd be great. Because it really shows nicely how the nucleus sticks to the annular tear in a sheet-like fashion, holding the tear open. And that's why the disc never heals. Because all this blue stuff is stuck down right here. Just keeping the tear open, allowing more and more herniations to come out. So I'm removing a piece of herniation right here with the laser. For those of you who don't know, that laser fiber is glass, and it's literally 1 millimeter wide. So that gives you a reference point in terms of diameters and sizes. Look at that. Guys, see it? The little metal thing right there?
Yes, we do.
That's the needle on the other side. Can barely make out the tip right there. Okay, remember we're doing a double on this one, left and right. That's the needle from the right side. Pretty cool, huh? All right, you can see the tear, herniation. Yeah, it may be more blue. I'd be interested in trying a few more and just seeing, you know, if there's a difference between the two amounts, Luis, whether you use the 5 or the 10, and just see if it makes a big difference. Because this is the way I like it right here.
Yeah.
And I'm just wondering if maybe they're just putting less of the dye in per milliliter, you know? Despite what they say, that it's the same. This comes from the country that makes fake rice. I'm dead serious. They make rice out of plastic. You didn't know that? They got caught. You guys never heard that story? You heard about the baby milk, right? A couple of years ago? Fake baby milk? Oh man. Fake baby formula? Yeah. Huh? Oh yeah. That's no joke. Man, you got it? All right. Almost done. We're at the end of the disc. You guys see that? We're right outside the disc here. This is the end of the annular tear. What you're actually seeing there, just above the fiber, is the posterior longitudinal ligament and foraminal ligament. So when the posterior longitudinal ligament travels from the back of the spine to the side, it goes out the foramen and becomes what's called the foraminal ligament. That's for neuroforamen. One minute left here and we'll be done. Which side is the DPR?
Your side, left side.
So we'll do this last disc and then we'll do the DPR,
Yes, sir. Okay.
right? A little bit of scar